Okay, great to have you back here. Thank you for being on time. I just want to announce a few other things. Tomorrow, please think of taking your sports shorts with you because we will do the TBT exam, and I think this is would be more practical for you if you had like shorts with you, not the long trousers. Also, we want to thank our colleagues who are here from Sono für Mannheim and from the Notfallinitiative Heidelberg, who are like supporting us in tutoring you and or supporting us in doing a workshop. And we're very, very grateful for your help and for your support. So thank you very much, our colleagues. Okay, so today's subject will be the shocked and hypotonic patient. And we are thrilled to have a real expert on the topic here for us speaking today. He's an emergency physician at University of Maribor in Slovenia. He's president of WINFOCUS Slovenia, which is a medical society standing for World Interactive Network focused on critical ultrasound. Please cheer for Dr. Gregor Prosen, sharing his knowledge and expert opinion on the Rush protocol.
Hello, guten Morgen. Can you hear me? I will revert to English. My Deutsch is so, so I think I make less of a fool of myself if I do it in English, so please excuse me. But I guess you guys are perfect English speakers, so hopefully we'll have a good hour and a half. Thank you very much, Leonard and Simon and David, for the invitation. I'm Gregor Prosen. I come from Maribor. For all of you, I guess all of you know that, where that is. It's just down the highway to the right. I work in pre-hospital officially. I work half in the EMS, pre-hospital, Rettungswagen, and half in the ED. I work 1 or 2 shifts in the HEMS, and I also used to work in home visits. So it's a good mix of everything. I'm emergency physician by specialty, so this is my focus and this is my point of view. And as you have imagined, I use ultrasound, I dare to say the tool that I use most truly on a daily basis. I would like to put an disclaimer and be very honest with you. I'm a very simple man. I'm an emergency physician. I like to see life in pretty much black and white because I have to decide in very black and white manners. I don't have time and nerves and knowledge for high philosophy because I have to solve practical problems every day. And also, ultrasound for me is a very basic tool, and I like to perceive it as something as very basic, but the skill of this basic tool is not necessarily basic or superficial, okay? And I would like to appeal to you as well, please try to understand what we are talking here, and then you will just perfect your skill. And please understand it from the very basic pathophysiological level, because later in your life you will be able to build on it. I have worked now in clinical arena 12, 13 years. I still have 2/3 ahead of me. I cannot imagine the challenges that you will face in your professional career. So you will be very well prepared for it, especially with sono skills, with ultrasound skills. There's no doubt about that. And my kudos and my gratefulness and my sincere admiration of what you are doing here. I've met Simon when we did our first ultrasound, Ultrafest, in 3 years ago, 4 years ago, and what you guys, and we invited some Graz University students, and what you guys have done here is absolutely mind-blowing. So without further ado, let me talk about rush. Have you heard about the rush? Please, let's make it interactive. I don't want to be on the podium. Just shout out, raise your hand, whatever. Have you heard about the rush? You know what it is, right? It stands for rapid ultrasound in shock, correct? Okay, let's walk through. And then later we'll do some hands-on, and then we'll try to make sense of it all, okay? So, in the essence, we will go through why we use that, what is this, and how exactly to do it. Like many things in life, you can help yourself with this knowledge. Why the hell am I doing something? Sometimes, or many times, people don't ask themselves. I think with this lecture it's fairly easy. We do it to identify shock causes, and how we do it, how we proceed it, we will go through the lecture and the hands-on. So my learning goals would be that by the end of this lecture and by the end of this afternoon, you understand what rush exam means and why we would use it. So indications for it, what are the key components of it, which I believe you already theoretically at least know and you have already practiced these days, correct? So we will just put the things together. And then, of course, most importantly, how to interpret it in clinical context and how to use it, okay? Because otherwise, if we do the best study in the world but misuse it, it would only harm our patients. So why? I think this question is fairly easy to identify causes of shock, but not all causes of shock. So maybe by this few days, or maybe you're already sono-pragmatics, you came to idea that ultrasound is very potent, omnipotent. It's not. It's a very useful tool, but it's not omnipotent tool, okay? So some causes of shock you can identify. For some other causes of shock, we need our clinical gestalt or EKG and so forth. But before we delve into the technique, I think the most important question to answer is, what is shock? Who can explain to me in very simple terms? Any ideas? What is shock? Okay, when I was working in the minor trauma, there was a boy or a girl, student or studentess, coming from minor injury with a car crash, and she or he would walk in and say, "Oh, I was so shocked." And I said, "Okay, what happened? What was your blood pressure? What was?" And of course, they meant psychological shock, right? I don't care about psychological shock. I care about pathophysiological circulatory shock. So what is it? Now, I saw your faces that were pretty quizzed. Like, intuitively you know what it is, right? But it's quite hard to say it out loud. And to be honest, it took me like half an hour yesterday to find appropriate definition that I think is pathophysiologically close enough from my understanding or definition that I have learned what shock is. And basically that is inadequate delivery of oxygen and nutrients to the tissue. Does that sound right? And you wouldn't be surprised if people have a whole consensus conferences on what the hell shock is, not to mention how to treat it, just what it is. But okay, since 2014, it seems like some smart people have decided this is shock in the very broadest term. So shock is a state, pathophysiological state, where nutrients, mainly oxygen, foremost oxygen, is not delivering to the tissues adequately, okay? And of course, if this state of shock persists, there arises first cell and then tissue death or failures. Correct? Does it make sense? Okay, so that's definition. So shock is a state of impaired delivery. And the hashtag here is delivery, impaired delivery of oxygen and nutrients. Does anyone know what this formula is? We all come from Central European bases, very strong on pathophysiology. I'm sure as my students, you were pimped and quizzed what this formula is. Anybody knows what it is? I would dare to say this is formula of life. Please tweet that. This is formula of life. Any ideas? What this D stands for? Oops, that doesn't work. This D, yeah. What does it stand for? Oops, I have to go back. It stands for oxygen delivery, right? And oxygen delivery is a product of cardiac output, so how much the heart spits out its blood, and then of course, product of what and how much oxygen there is in the unit of blood. Does that make sense? Have you seen this formula? Yes? Yes or no? How many hands up for yes? Okay. How many for no? Okay. You haven't gone to the same university? Same lecture? Anyway, it is important formula because it shows us how oxygen is being delivered to my toe. Okay? Let's say toe is very unassuming part of the body. Who cares about toe? I can chop it off today, I'll live on. Okay? But even the toe, cells in my toe, they also want to get oxygen. Okay? So how is that oxygen delivered to them? By function of cardiac output and oxygen concentration, which is mainly bound on hemoglobin, we know that. But mostly here the mechanical part is hidden in cardiac output, which of course is function of heart rate and stroke volume. And how is stroke volume defined? It needs some preload, right? It needs some ionotropy, contractility, and there is afterload or resistance against which the heart pumps. Does that make sense? Okay? So in this universe, we will address the shock and the use of ultrasound as such. As I said, the formula is quite important, one of 3 formulas that I demand understanding of from my students. But otherwise, I'm a very fairly simple man, and I see circulation as a very simple system of a pump. You agree with that? There is something in it to pump, blood, not too much wine, mostly blood. And there must be pipes, right? That bring this blood to the tissues. Make sense? Okay, so this is normal physiology. And what is shock? What is shock? If any element of this goes wrong. So what failure can we have? We can have pump failure, correct? We can have content failure or blood loss or volume loss, makes sense? And we can have, of course, failure of pumps. Either the pumps are blocked or they are leaking. Yeah? No other possibility. This is the grand scheme. You agree with that? Okay. Now, question number 1. How do we recognize that something in that circuit was wrong? A, we measure this delivery, because as I said, delivery, shock is inconsistent delivery. We recognize it clinically, whatever that means. We measure blood pressure. We measure lactate, or all or none of the above. So how many for 1, for A? 1. How many for B? Clinically. How many for C? We measure blood pressure. 3. How many for elevated lactate? Yeah? Makes sense? Then how many of you for the last question, for last answer? Okay, hopefully you agree it's pretty much most or all of the above. It's a combination of it all. And this is sort of the beauty of this art of medicine, and also tricky part, because we are not very, very specific, especially in everyday average clinical scenario, where upfront with a patient, you have to recognize its shock. It reminds me a little bit of this justice, the Stewart, when he was, I think he was prosecuting pornography in 60s. And he said, then how do you define it? And he said, I don't know how to define it, pornography, but I know when I see it. Make sense? Yeah? Shock for me is a little bit like this. I don't exactly know how and why I define it as such. It's a mix of everything, but I know when I see shocked patient, or presumably I think I know. Okay? And this is pretty much how we all clinicians have to operate. Medicine, especially emergency medicine, critical care, is a very mind-ridden field. You don't exactly know, you just jump and hope you survive, and your patient as well. So, and in another journal, where it's a New England Review Journal article, they said that the shock is recognized on basis of these main 3 clinical pillars. So, clinical, hypotension, signs of hypoperfusion, and laboratory markers. And the clinical signs of hyperperfusion in terms of cutaneous, how does the shock patient look like? In terms of skin changes. They're pale, yeah. Their skin is also cold, sweaty, agree? How is their renal function? Decreased. How do we recognize that it's decreased? Through urine output, agree? And neurologic. People become altered if they don't have enough delivery of nutrients, agree? And also one marker is lactate. But not only lactate, because yesterday when I ran my 6 kilometers, I also had elevated lactate, but I was not in shock, okay? The context was not right. And second thing that makes things even more complex is that shock, of course, is a spectrum of occult shock to the decompensated, irreversible shock, right? And all these landmarks that we put are just landmarks, like sometimes in the table, during the ATLS, the trauma, you will see that shock type number 3, stop shock stage number 3, is defined by hypotension. But you are already shocked before being hypotensive. And now my point here is that to help a patient who is in irreversible shock with hypotension of 60/40, sweaty, cold, lactate of 12, and will develop irreversible tissue damages and failures, multi-organ failure, that's not the patient that is focus of my thinking, of my specialization, because that patient might be lost. What the true art and the added value of being doctors and healthcare providers is to recognize patients who are just starting to be shocked or developing their shock, reverse the cause, treat it, and make them alive. See what I mean? We should not let them to decompensate all the way down. It's easy to recognize such shock patient there. Now the tricky part is to recognize what treatments he needs in this phase. Okay, enough of philosophy. Just one reminder. We recognize and treat shock in a little bit of a reverse pattern. Because namely, in clinical practice, we see signs and symptoms of shock. And then we work backwards, saying, aha, this patient is in shock. He's not in epileptic state, or he's not in respiratory failure, he is shocked. And then, after stating that he's shocked, we would look for causes. Does that make sense? And then, when we know that we have to look for causes, this is where ultrasound kicks in. Ultrasound amongst other measurements, but mainly ABCDE, primary exam, vital signs, EKG, and ultrasound. All of it, the whole bundle. Okay, so finally to the rush exam, rapid ultrasound exam in shock. It is actually a poster child for the whole POCUS concept. You know what POCUS stands for? Point of care ultrasound. That's what it is. And FOCUS, let's say, is focused cardiac ultrasound. And this rush exam, where we put many little applications together, is pretty much the level that I would expect every emergency and critical care physician to master, because it's putting together all the little pieces for the one very big chunk of problems that patients have, circulatory failure. Another chunk is respiratory failure, and the third chunk is neurologic failure. Okay? About psoriasis, I don't care much, except if they produce any of these failures. Okay? This is my specialty. I'm not saying that dermatology should not care about that, but my role is such. And by definition, as a poster child for POCUS, it is founded on a premise that you recognize patterns. You take one bit of information here, there, history, and put it together. And this is why it's so strong, because it doesn't take a very profound specialist knowledge, but you have to take a big picture and zoom in when necessary. We'll talk about that. It is transversal, it is multi-system. It's not just about the heart. It's about combination of veins, IVC, heart, and lung. Or in cardiogenic shock, about pump and the lungs and IVC. And of course, clinical data. You palpate their pretibial edema. You ask them questions. Okay, but we'll come to that later. And this transversal point of view, taking bits of information, past medical history, physical exam, primary exam, one POCUS application, second, third POCUS applications, this is what produces synergy. Or in visual terms, pattern recognition. Computers don't scan whole face, but they scan strategic points, and they reconstruct the picture and recognize it. Multi-system and synergy is something where if you would put things together as a pluses, the sum is bigger than the arithmetic sum of it. And this is the power of ultrasound, because it's so powerful in few factors that you put in. What are the causes of shock? I think you agree with this classification. We would then also add the fifth one, the cellular shock, the cellular intoxication, but that doesn't matter here. From a mechanical point of view, there are four major groups. You agree with that? Cardiogenic, hypovolemic, distributive, obstructive. Okay, can you help me? Where can we help ourselves with POCUS? Which branches? Obstructive, yeah? Anything else? Cardiac, yeah. Hypovolemic? In what terms? To see the cause? Yeah, also? Okay, let's go through. Starting with hypovolemic. Can we help ourselves with POCUS regarding identifying hemothorax? Yeah? Yes or no? Yes or no? Yes. How about hemoperitoneum, or blood in peritoneal cavity? Yes. How about blood in retroperitoneum? No? Okay, how about the cause of retroperitoneal bleeding? Do you know any such cause? In the retroperitoneum, one structure burst. What's that? Injuries, yeah? Kidney injury? Or any internal cause? Something burst, boom, and you're dead. Aortic aneurysm, right? It is a retroperitoneal structure. That's why it hurts to the back. Okay, yeah, we can help ourselves there. Fractured femurs. I hope you will say that you see that you have broken legs, but yeah, you can see fracture as well. GI bleeding. Hopefully you stick the finger in appropriate holes, ask questions, but you can see consequences. Dehydration, certainly of any sort, you can see as a consequence. Sepsis. Now this is a tricky question. You can look for causes of sepsis that might cause septic shock, and you can also see hemodynamic consequences. Collapsed IVC, kissing ventricles of severe dehydration, severe hypovolemia. Neurogenic shock. Yeah? Would you use ultrasound for that? Anaphylaxis? Hopefully not. Anaphylaxis is clinical diagnosis, and such patient needs EpiPen in their butt. Yeah? Obstructive tension pneumothorax, although I would argue the more the tension, the more the clinical diagnosis, but we'll come to that. Massive pulmonary embolism. You agree with this one? This is another poster child of multi-system POCUS exam. Cardiac tamponade. Yeah. I went to these ALS courses when I was a resident, and I remember that was before the age of when we had the POCUS machine. And there, you remember, there are these 4H and 4T reversible causes of cardiac arrest. You know what I'm talking about? So what is one of the T's? Tamponade. And then I asked, well, how do I know it's tamponade? And of course, there was no good answer, because without ultrasound, realistically speaking, there's no way you can know someone is dying from tamponade, except they were just knifed towards the heart, okay? So tamponade, fairly rare. Even severe aortic stenosis, ionotropy, how much the heart is squeezing, you can see with ultrasound. Dysrhythmias, can you see that with ultrasound? You can, but the question is, why would you? How would you recognize dysrhythmias, tachy or brady? With EKG, please don't forget that. You can see anything with ultrasound. The only problem, there are only two problems. Do you know what you're looking for and how to realize and how to recognize it? And do you have better other tests? Does it make sense to see how fast the heart is going, right? We can see that on the pulse ox. And of course, mechanical, valvular rupture, wall ruptures. Okay. So coming from this perspective, I was lucky enough to start before the dawn of POCUS, which came to us in 2008. So 10 years, we should celebrate that. And I honestly must say, my life has been much easier, and I cannot understand and realize in how many clinical doubts our forefathers had to be, because they simply didn't know. They just assumed. They just, palpated and Oh, the fluid is until here. Yeah, let's stick. Oops. Nowadays, you can see exactly to the millimeter where you have to stick. Okay, and another revelation was that there are sonomojis as well. You will see them in my talk. I found it yesterday on App Store for €1. Please use it and spread the love. Okay, so to the meat of the matter. What can be seen by POCUS? I think we've done that. And how to visualize it. The original Pereira article, I believe, where someone described all this concept and put it in one recipe, was in 2010. That supposedly is one of the first articles, at least that I know, in clinics of emergency medicine. And this is where they put it into, let's look for 3 pillars. The pillars that I taught you before, right? The pump, the content, and the pipes, right? So this is how they put it. The pump, the tank, how much water or blood there is, and the pipes. And regarding the pump, of course, we would look at the heart. We would interrogate the heart through the 4 chambers. Have you done that? You've done that. So classical basic echocardiography or focused cardiac ultrasound, looking for IVC, for preload, afterload, or ionotropy. What is IVC function of? Preload, afterload, or squeeze? Preload, right? The heart has to be filled. Something has to come in so that it can spit out. Preload, and then 3 classical view, parasternal long, parasternal short, and apical 4 chambers. Regarding the tank, again, how much preload there is, or is there anywhere leaking? So fast exam from for intraperitoneal bleeding in context of trauma or possible bleed, or other intraperitoneal fluid in internist causes. And don't forget about the pipes also in terms of interstitial syndrome, pulmonary edema, where the pipes are leaking. Okay, this is this part. Sorry, that was tank. And the pipes as such, aorta, descending aorta, ascending aorta, the arcus, and DVT. Okay, makes sense? Have you got this? Makes sense? I think you also have it in your handout. Now, people have defined it indifferently, tanks, heart, pump. I would like to stick to the European notion of A, B, C, D, E exam, where we would go from A to the B, where let's say pulmonary edema would be covered, but mostly all these applications are under C, circulation. Americans like acronyms, and they go for high MAP, which is sort of reminding you want to ensure mean arterial pressure, right? Some basic perfusion. And the high would be, what do you think? The heart, right? The I would be IVC. M would be Morrison, or fast exam. Aorta and pulmonary, okay? Or pumps, pipes. Okay, so whichever way, I don't care, as long as you put these basic applications together and use it sensibly. And this is the beauty of Lego, and this is the beauty of POCUS, and this is the beauty of clinical medicine. You don't use only one application in isolation. You put it on top of shocked patient with certain signs and symptoms where it hurts, how they breathe, and then you do different applications that we'll put together, okay? And then you come to the correct diagnosis. So finally, how to do it? First window, I would say let's go from the B, and mostly it's up there, furthest up, is looking for lungs through the transcostoid thoracic view. Anterior, little bit lateral. What do we normally see? What is this profile called? Have you learned about that? The lung profile? What lines do we see here? This one. A lines. So this is A profile. You agree? And one line somewhere here should be doing what? Sliding. It's called lung sliding. Like the how you call that in German? The shield? The form, yeah? No, the texture that is coming down. Yeah, the forehand. As forehand, it has to move left, right, okay? Because if it doesn't move and the patient is dyspnoic, take a look here. If it doesn't move, see, nothing is moved. The forehand is not moving. No lung sliding, dyspneic patient, what would be your working diagnosis? Pneumothorax, correct? Agree with that? And the bigger the location of no forehand movement, the bigger the pneumothorax, right? There is also another pattern. You recognize this pattern where we have vertical lines? What is this pattern? What are these lines called? B lines, so B pattern. And if it's diffuse everywhere and pretibial edema, what would that be, most probably? Pulmonary edema, right? So this is visualization of pulmonary congestion. Make sense? Okay, so lung view. Posterior lung view, not sure if you can see it, but here would be livers, and here comes the forehand and stops. What is this area here called? Sinus phrenicocostalis. You agree with that? So this is the border of lung, and here would be liver, abdomen. And what we see here is an A profile, which means there is no fluid. We would look for fluidothorax here, or hemothorax here, posterior. Make sense? Fluid goes down, air goes up. Yeah? And this is how fluid looks. You see diaphragm here? Diaphragm, probably spleen or liver, and the sea of fluid. Fluid in thorax. It's called fluidothorax. Simple. Medicine is simple. Don't complicate too much. Okay? If I could pass this medical school, and everybody can do it. Then the first pump, or even the circulatory application, is vena cava inferior. You agree with that? Subcostal longitudinal view, little bit to the right. This is where vena cava inferior flows into the right atrium. Yeah? And if it's big, it's probably, what would tell it? Yeah, big filling pressure. And if it's collapsed, small filling pressure, probably hypovolemia. What cause of hypovolemia? Well, then you need other applications or other history factors. It just tells you the preload is low, the tank is empty. Yeah? Roughly speaking. You see this vena cava here? How big is this one? Small, medium, large, or extra large? Small. Okay. Italians name this application Santa Cava. You know why? Firstly, because they are a poetic nation, but beside that, they say it's Santa Cava, especially in shock state. Why? Because in average shock state, there is very good chance that patient might be fluid responsive. You see? Sepsis. Even cardiogenic shock, to a certain extent, they could use some small fluid challenge. But mostly sepsis, tamponade, PE, they can tolerate small fluid challenge. Only florid pulmonary edema, you would hurt them. So in the shocked patient, You can argue the first question is fluid or no fluid. You take a look at vena cava inferior, you see such empty collapsed vena cava, nurse, 1 liter of fluid. Very, very liberally. I'm not saying this is absolute true, but this is something where you can be quite liberal with the fluids. And then later on, of course, you check and see, oh, cava is getting bigger, then of course you don't repeat the fluids ad infinitum. It's dynamic. Okay? So that's why they call it Santa Cava, fluid or no fluid. Easily check, it takes like 3 seconds. Then the heart, first view, you recognized, which one is this? So probe parasternally, marker towards right shoulder. This is parasternal long axis, because it's in the long axis of the heart. You see, the heart is actually a little bit like a, heart is certainly not the shape of the emoji heart. It's more the shape of the aubergine, okay? So it has apex, it has the left ventricle. You know this view? This view, what could be? Is there, yes or no? Why not? Because if this is posterior wall, and I trust you that you know it, if this is inferior or posterior wall, we won't go into semantic, this is pericardium, this white is pericardium, there is no fluid. Agree? So no pericardial effusion, no person to see the left ventricular function, and the right ventricle up there looks roughly appropriate size. For further interrogation, of course, you need motion. Consider this versus this heart. How is this heart in terms of function, contractility? What would you say? Look at the screen. Good, bad, or ugly? Can we play it once more? The one, yeah, the video. How does it look? Good, bad, or ugly? Ugly? You agree with that? It's quite ugly. Now, I don't want you to think about, oh, is this ejection fraction 17.5 or 27.5? I would like to think you, and I would like you to develop the sense that can this patient be shocked because of ionotropy failure? What do you think? If you have heart pumping like this, could this patient be shocked? Trust me, this is shocked heart, okay? This is not the heart that you saw yesterday on your Hanzo. It was beating vigorously, happily, and then you do the 10 push-ups and the ejection fraction is 70%. No way. This ejection fraction is low. I would even dare to say that I would like most physicians think about this classification, good, bad, or ugly, in terms of is this patient shocked because of pump failure, or rather, does this patient suffer from hypodobutaminemia? You know what is dobutamine? It is what? Ionotropic agent, right? So does this patient need ionotropic support? Does he need it? I would say yes. If this patient is shocked, yes. Okay, parasternal short axis. Classical view. You heard about the donut sign. You see this cross section of left ventricle? Donut, nice. American donut, not our steirische donut. American donut. And you see the nice convex septum and the croissant sign. You see the right ventricle here is like a lunar, like croissant, okay? It's not bulging on the left ventricle. It stays there. So that's how it should be. And remember, this is inferior wall, and there is no fluid there, right? So even from the still image, you can tell a lot. Contrast this with this image where this left ventricle is being squeezed by which is not croissant anymore, but a big chunk of pulmonary hypertension pushing on the left ventricle. This is called D sign. You see, because it's a D. Okay? And it's in the right context, it might be massive pulmonary embolism because of acute pulmonary hypertension. Yes? So now we're putting things together. Dyspnea, probably central chest pain, some risk factors for DVT or PE. Maybe we find the DVT, the thrombosis, and then we see the hemodynamic consequence of this clot going into pulmonary arteries. Make sense? And we did not see the thrombus in pulmonary arteries. We saw consequences, okay? But enough. If this patient has 80 of saturation, 80/60 blood pressure, we would push which medication? Massive pulmonary embolisms, what medication this patient needs? Thrombolysis, right? Because have to dissolve this clot. And even if you will not push it, and even if I don't push it in Rettungswagen, at least we will drive 160, and I will call, and I will ask for someone who is more experienced to confirm it, and this patient gets a bed in ICU straight away. Okay? This is the power of focus. Because you can advocate for patients. No one can then say, oh, maybe he has pneumonia, maybe they have some heart failure. Very unlikely. With this sign, very unlikely. Apical 4 chambers, I think very intuitive view, right? Excellent for anatomy teaching. You can see the apex up here, you agree? The base here. Left ventricle, bullet-shaped. Right ventricle, more triangular and small atria. Atria should be half the size of ventricles. Okay? And many a times, and I'm not cardiologist, I just put the probe on. My residents put the probe on. And we see atria that are bigger than ventricles in old ladies. Now, tricky question for you. What rhythm, cardiac EKG rhythm, you think they are in if they have huge atria? Exactly. And then I know that I will not even try with amiodarone because there is no way they can come out of atrial fibrillation because their atria is so big and re-entry in there will be there forever. But that's okay. She can live with that. Okay. Based on what you saw your hearts these days, how does this function look like? Good, bad, or ugly? What's that?
It stopped.
Yeah, okay, now it stopped. Now it's asystole. But before? Good, bad, or ugly? Is it normal? No. It's either bad or ugly. Okay? The beauty of it is that you too, all of us, even I have learned, if you die like 2 dozen, 3 dozen exams, you can learn it. But you have to learn this feeling of eyeballing with some supervisor, with mentor, preferably in cardiology lab. So they will measure the ejection fraction, but you get the feeling, aha, this is how this heart looks much worse than what you students did in Sono Graz. Okay? And you will develop the feeling. You will develop gestalt. Subcostal view, very useful in cardiac arrest, because once you put the gel on here, those that are massaging, usually paramedics, they cannot massage anymore. They'll hate you because it slips. So you're stuck to the subcostal view. Okay? And what can you see? You see the heart. Does this heart have any fluid around it? Does it have any fluid around it? No. So 1 T from H and T is out. And I need like 3 seconds. Sick. No tamponade. Not only no tamponade, the left ventricle is considerably bigger and the right is much smaller than left. So most probably, no massive PE. Okay, so no thrombolysis in this patient. And this is already a lot. And if this state persists after 20, 30 minutes, there is no movement at all, most probably bad diagnosis. Yeah? Or if there is movement, then we do everything for this patient. Because if there is some movement, even if no pulse, this state is called pseudo-PEA, pseudo-PEA. You know what is PEA? Pulseless electrical activity, but pseudo. There is some movement, but no pulse. So technically cardiac arrest, but then you will put maximal effort into this patient because they have much better prognosis. Look at this patient, look at this heart. Does this man have a heart? He has. Is this heart beating? Yes. But around this heart, you see this? What is this? A mouse? Huh? What is it? It's actually hemorrhagic, no? It's already clotted. It was hemorrhagic tamponade. Yeah? And this is huge, because if you see that in pre-hospital arena, most importantly, you will try to go somewhere where they can operate this patient because there's some surgical cause of it, most likely. In this case, actually, it wasn't, but doesn't matter. Okay? And this is different from internists, let's say, oncology cause where patients have big pleural effusion and they can develop tamponade and you simply just puncture it. Okay? This patient, it's much harder to drain hemorrhagic tamponade. Classical fast, I will not dwell into it too much. Aidan yesterday gave you an excellent talk on that. Classical fast, Morrison, perisplenic, Douglas. You agree with that? We look for intraperitoneal fluid, perisplenic, spleen. Look at this small amount of fluid. You see? This is already positive fast. As you heard yesterday, in fast, we don't measure how much. We just say yes or no. That's why I told you it's easy. Like someone who invented this ultrasound, they were thinking of me because I'm simple man, yes, no. Fast, yes, no. Trauma, yes, no. And of course, Douglas. Technically speaking, Douglas is uterorectal place. So this is actually vesicorectal. Douglas is only girls own the Douglas space, but doesn't matter. It's the same most inferior part of peritoneal cavity, yeah? If patient is lying down or sitting. If they're in Trendelenburg, it's not most inferior anymore. But practically speaking, in trauma patients, of course, they're lying still. You see here some fluid? Yeah, makes sense? So positive fast. And vesica urinaria, prostate, vesica seminalis, no fluid around, no fluid. Aorta, fairly simple. You find the spine. You've done that, right? No? Okay, you find the spine, and on the spine, little bit to the right, to the left, is usually aorta. And how you see, it's very circular, pulsating mass. And you measure it from 12 o'clock to 6 o'clock diameter. How much is normal diameter of abdominal aorta? 1 centimeter, 2, 3, 4. You've done anatomy, right? You've done anatomy on cadavers. How big was that gardenia hose? It was like gardenia from the OB, 1.5, 2 centimeters. Yeah? If it's more than 3, or if it's more than, at any level, more than 50% outpouching, it's called aneurysm. Yeah? Mostly there are inferior infrarenal, inferior to renal arteries, so you can see them with ultrasound. So over 3, and the bigger they are, the more likely they are to rupture. Okay? And they really like to rupture after 5, 5.5. Okay, so 3.5 is still okay, but technically speaking is aneurysm, and such patient needs follow-up. And sooner or later, probably elective surgery. What happens if this gardenia hose explodes? Is it abdominal? Okay, where does it hemorrhage to? In which cavity? Retroperitoneum. And this is where all of you agnostics have to think about, maybe there is God. Because if God put aorta intraperitoneally, what would happen? No one possibly could survive rupture. But because it's retroperitoneal, the retroperitoneum can tamponade, patient develops symptoms, they collapse, they shock. I come, I see, I call my vascular surgery. In 20 minutes, 30 minutes, they're on the table. If they rupture intraperitoneally, it's pretty much game over. Okay? Understand that? Very high mortality once it ruptures. Look at this monster on the vertebra. You see, here would be the marker. This would be 10. This was 8 centimeters across. From 12 o'clock to 6 o'clock. You see what is this? This is mural thrombus. And the false lumen actually is so small. So you have to measure with the thrombus, together with the thrombus. Okay? 8 centimeters. And last pipe, DVT. Please pay attention. We put this patient, maybe he was too much shocked, in reverse Trendelenburg, legs down. Preferably, you would want them to sit up. But if they're shocked, they cannot sit up. So why legs down? Why? There is very simple reason. As I said, if I could pass this school, there must be simple and logical explanation to most of it. Because you want your deep veins to fill up with the fluid. Yeah? So you can better see them, and then you see them. If this is vein, what is this structure here? Artery. Where is medial? Where is lateral? How does it go, this femoral triangle? Yeah? So, medial, V-A-N. Yeah, correct? Vein, artery, nerve. And how do we recognize one against the other? Because remember, in Sobota, it's written, and it's blue and it's red. In the real life, it's not. Exactly. You compress, and the medial part, the vein, should be completely collapsible, because how much pressure is in that pipe? How much pressure? No, not really. How much pressure is in vena cava just before entering the heart? Little bit less, 5 to 10. Yeah, millimeters. And then how much in the femoral vein? 2 more, 7, 8. The point is much smaller than in artery. How much is in artery? 120. If you're shocked, hopefully 80, 90. But certainly much easier to compress vein than artery, right? And if you cannot compress it, and even you are compressing the artery already, then what's the reason? What could be? The only logical explanation, thrombus, right? Something is preventing complete coaptation, complete collapse, okay? So indirectly, even if we don't see the echogenic mass of thrombus, we see, oh, based on the symptoms and signs, there is something inside. And if my patient now developed dyspnea, shock, syncope, maybe some of the residue already flew out. And then we deduce logically, okay? Popliteal vein, similar. Compare here to the collapsed. Here, you can't see too much, sorry. Okay. And one last application, which is a little bit exotic, but very sexy, especially in young students, because we can see it. You see how I put it here? Suprasternally, looking down. What is this beautiful structure going like a arch? Arcus aorta. Agree? And if this is right, because marker was there, if this is right, what is the first exit? Yeah. The second one. And the third one, traditionally, normally, would be, yeah, or truncus, right? They come together in the trunk. Yeah, okay. So beautifully, you can see the arcus, but this application, we would try to see if there is something floating inside, like a membrane, dissection of aortic arch. Not too much, not too good sensitivity, but specificity is okay. So if you see it, but most importantly, patients have the signs and symptoms, then you shoot, you run for CT angiography if they have enough blood pressure, okay? And you advocate for your patient. So these were now basic Lego bricks. 1, 2, 3, 4, 5. But the true beauty and the utility is if you put all these bricks together. Then it starts to make sense. And this is beauty of medicine as well. If you only take one information out of the context, it's useless. But you put it with signs and symptoms, physical exam, vital signs, and sono, POCUS. And again, pattern recognition. Okay, so the cases we can do afterwards. Short break now. And I'm only 4 minutes over. Please congratulate me for that. Thank you.
Yes, I think we'll take a question. So thank you very much, Gregor Prosen. Are there any questions from the audience? Anything? Well, I have a question to you. How fast can a BFAST be done by an experienced sonographer?
2 minutes.
2 minutes.
Faster than they put all the blood pressure, EKG, and everything on. But I would advise against that. Because the faster is not necessarily better. Okay? And yeah, but it can be done. Okay, your question was, it can be done. It can be done.
Okay, thank you very much. Well, we'll do a short break and we'll start again at 10:40. See you in 10:40.
Thank you.